Next we'll be talking about treatment of intraocular foreign bodies. So if there is an intraocular foreign body, it's not necessary that we have to treat and remove each and every foreign body. A treatment is not indicated if the foreign body is inert and sterile, that is, it's not going to cause any further damage to the eye. If the foreign body is not going to cause any damage to the vision, and if the process of foreign body removal will invariably go and destroy sight. So in these cases you will not go and intervene and remove the intraocular foreign body. If there is a intraocular foreign body, then it's important to manage the open globe injury. So open globe needs to be protected, so we apply a eye patch on the eye so that the eye is not going to get any further damage. Need to start the patient on IV antibiotics as infection prophylaxis. Also give a dose of tetanus toxoid, which is a tetanus prophylaxis. It's very important to immediately close the globe so that more of the intraocular contents don't come out and there is a less chance of infection which can happen. So this closure has to be done under guarded visual prognosis. Patient has to be explained the possibility of poor vision post the repair. Depending on the location of the foreign body, each one of the foreign body is managed. So if the foreign body is in the anterior chamber, then we need to make a little incision into the anterior chamber through the limbus. So we make that incision with a paracentesis blade. And if it is a magnetic foreign body, we can remove it with a handheld magnet. If it's a non-magnetic foreign body, we can use a forceps like this in the second picture and we can remove the foreign body. If the foreign body is in the iris, then we can do a sectoral iridectomy because it's difficult to remove a foreign body once it is entangled inside the iris. If a foreign body has entered the lens, then we have to do a lens extraction because it's pointless removing the foreign body because the patient will eventually develop cataract. So we have to remove the entire lens and place a intraocular lens if possible, depending upon the stability of the capsular bag. If a foreign body is in the retina or the vitreous, if it's a magnetic foreign body, then we can do a direct extraction with an intravitreal magnet or a intravitreal forceps. If it is a non-magnetic foreign body, then we'll have to do a bit of pars plana vitrectomy, followed by removal of the foreign body with the intravitreal forceps. And after this, we need to do a little laser photocoagulation of the surrounding retina because it's important that we stabilize the retina because the retina becomes a little weak once we do a vitrectomy. So stabilization of the retina is done with a laser photocoagulation. How do we treat the associated ocular damage? Now they can be retinal tears and retinal detachment once a intraocular foreign body has entered the eye. So how do we manage these retinal tears? There are two types of retinal tears, those which are located at the site of the intraocular foreign body impaction and those away from the site. So we can do a cryotherapy or a laser photocoagulation along the margins of the tears so that the tears don't further enlarge and develop into a detachment. But if detachment has already occurred, then we have to do a reattachment technique to reattach the retina. So we do a vitrectomy followed by a retinopexy. Retinopexy is basically a procedure where we are reattaching the detached retina. So it's of two types. You have the pneumatic retinopexy and laser retinopexy. So pneumatic, as the term suggests, that we are injecting air inside the retina and using that air to reattach the detached retina. Laser retinopexy is where we do a bit of laser at the margin of the detached retina and we stabilize it. Scleral buckle procedure is a reattachment technique where we take a silicone band and we attach it outside the eye along the sclera. So we are supporting the detached retina from outside here, whereas in retinopexy, from inside we are either injecting air or doing laser. So these are how we manage a detached retina and retinal tears. The next major complication of an intraocular foreign body is endophthalmitis, which is seen in 8 to 13% of intraocular foreign body injuries. Endophthalmitis is a very dangerous complication of IOFP, and it has the capability to bring about total loss of vision. Now, patient usually presents with pain, photophobia, redness, watering, and a sudden decrease in vision. When we send a vitreous tap or aqueous tap for culture, most common bacteria that we see are Bacillus, Staphylococcus, and Streptococcus. So these are the types of bacteria that we see on culture. So how do we treat endophthalmitis? It is very important to diagnose early and treat early. The more we delay, the lesser chances of visual improvement in these patients. So it is very important to immediately remove the intraocular foreign body, and we need to send a culture of the intraocular specimens like aqueous, vitreous, and also the foreign body itself can be sent for culture. We need to start the patient on intravitreal antibiotics like vancomycin with ceftazidime or amikacin. IV antibiotics also need to be started like cefazolin, ceftazidime, vancomycin, and ciprofloxacin. Suppose even with all your antibiotics, if it is not being controlled, then if we have to do a bit of vitrectomy. So vitrectomy itself will remove some amount of infection and inflammation. So that is something that we do as a last resort. So this is how we manage endophthalmitis in case of intraocular foreign bodies. The last topic in intraocular foreign bodies is sympathetic ophthalmitis. So what exactly is sympathetic ophthalmitis? It is a bilateral granulomatous panuveitis which usually follows a penetrating ocular injury. It is an autoimmune inflammatory response towards ocular antigens. Now here we see manifestations in both the eyes, the injured eye as well as the non-injured eye. So the injured eye in this case is called as the exciting eye, which is going to bring about changes in the other eye, and the fellow eye is called as a sympathizing eye. The incidence of sympathetic ophthalmitis varies from 0.2 to 0.5% after ocular injury. It is a little less after intraocular surgeries. It's around 0.01 after intraocular surgeries. The predisposing factors include penetrating trauma, which is a necessity for sympathetic ophthalmitis to happen. Wounds of the ciliary region, which is called as a dangerous area of the eye, are said to be more susceptible to cause sympathetic ophthalmitis. Wounds with iris incarceration are said to be at higher risk for developing sympathetic ophthalmitis. When we do a histopathology, what do we see? We see diffuse lymphocytic infiltration of the choroid, and we also see scattered aggregates of epithelioid cells which contain a fine melanin granules. We also see something called as the Dalen-Fuke nodules, which are classical for this. These are granulomas of lymphocytes and epithelioid cells, which are located between the retinal pigment epithelium and the Bruch's membrane. So Dalen-Fuke nodules is something that we see in sympathetic ophthalmitis. What are the clinical features? A patient in this case will have a past history of ocular injury. So the manifestations can be divided into those seen in the exciting eye and the sympathizing eye. So in the exciting eye or the injured eye, we see a ciliary congestion. There will be a lot of tenderness. We can see a lot of congestion right here. There will be a lot of watering or lacrimation. And sometimes if we are able to visualize the corneal endothelium, there will be keratic precipitates also, which are proteinaceous deposits which we see on the corneal endothelium. In the sympathizing eye, what are the features? The first symptom that we see in the sympathizing eye is difficulty in seeing near objects. This basically occurs due to a loss of accommodation. Whereas the first sign that we see is a retrolental flare. So flare is basically proteins that we see in the anterior chamber, and sometimes we see that just behind the lens as well. So that is what we call as a retrolental flare, which is the first sign of sympathetic ophthalmitis in the sympathizing eye. Apart from that, we also see photophobia, ciliary congestion, keratic precipitates, and if we see just behind the lens there will be a fine vitreous haze as well, which is seen in sympathetic endophthalmitis. Fundus examination shows multifocal choroidal infiltrates in the periphery. There will be some amount of vasculitis also, which is inflammation of the vessels of the retina. Optic disc edema is also seen. You are not able to make out the optic disc margins here. And once the inflammation subsides, the residual chorioretinal scarring that you see gives it a sunset glow appearance. So since this sunset glow fundus is something that you see in sympathetic ophthalmitis in the advanced stages. How do we investigate this condition? We can do a B scan and a UBM. So this is a picture, which first picture what you see is a B scan. So we are seeing some amount of choroidal thickening here posteriorly, and this detached area suggests there is a retinal detachment. So these are common findings that you see in sympathetic ophthalmitis on a B scan. A fundus fluorescent angiography will show multiple foci of leak at the level of the retinal pigment epithelium. So these are multiple leakage points that we are seeing, along with subretinal pooling in cases of exudative retinal detachment. So there will be subretinal pooling as well as lot of leakage at the level of the RPE. How do we treat sympathetic ophthalmitis? Now, treatment depends on the stage that the patient comes to you. If he comes to us before the sympathetic ophthalmitis develops, then the management line is different. If he comes to us after it develops, it is different. If the patient comes to us before sympathetic ophthalmitis develops, then we need to enucleate the injured eye. When do we enucleate? If there is no visual prognosis, and it's important to do this within 2 weeks of injury. Otherwise, sympathetic ophthalmitis would have already developed in the other eye. So that is the care that we need to take. If there is some amount of visual prognosis, then we can do a repair of the wound, repair of the injury, and we can start the patient on systemic and topical steroids along with cycloplegics, which is very important. Now, in spite of this best treatment, you wait for a couple of weeks. If it is still not being controlled, then you have to do a enucleation, because it can cause changes in the other eye. It can cause sympathetic ophthalmitis in the other eye. So it is very important to enucleate an eye which is not showing any response to treatment. So this is before the changes start to happen in the other eye. Now once changes have already occurred in the other eye, then what do we do? Then we'll have to enucleate the injured eye if there is no visual prognosis. What are the treatment modalities we can use in the sympathizing eye? You can use corticosteroids, both systemic and topical, to reduce the amount of inflammation. If the inflammation is very severe, then we'll have to use immunosuppressants. Atropine eye drops or eye ointment thrice a day has to be started in these patients as well, to reduce the amount of inflammation inside the eye.